Hi, and welcome to the Clinical Informatics Board Review course. This is Lecture 2C2, Healthcare Quality Improvement, and I'm your lecturer for today, Improvement Desai. So referring back to the CBRIC core content, this is Section 2.3.3, Quality Improvement Principles and Practices. And in the original core content board topic list, there's actually not a whole lot of subpoints here, but we're going to cover this entire very broad topic in this lecture. Here are some of the key topics and concepts that you should know. And here's the sequence that we'll do that in during this lecture. So first, let's talk about the American healthcare system and what makes it unsafe. And these next couple of slides, by the way, we're going to build the case for why quality improvement is important. And I think the logical place to start is safety. So if you look at medication errors, they're not just harmful and costly, they're also extraordinarily prevalent. In this seminal work from the Institute of Medicine to Err is Human in 1999, they estimated that there were 98,000 deaths and 1 million injuries annually at a cost of $29 billion. And to put that into context, based on the 2010 vital statistics from the CDC, that makes deaths due to medical error have higher mortality than diabetes, and places it just below heart disease, cancer, chronic lower respiratory diseases, accidents, stroke, and Alzheimer's disease. In addition to the 1999 to Err is Human paper, there was another manuscript in 2001, Crossing the Quality Chasm, that covers in great detail what makes the American healthcare system unsafe. One of the major categories of this safety risk is adverse drug events. In these papers from David Bates and Klassen in 95 and 97, they make the case that the rate of hospital adverse drug events is actually probably way higher than anyone had previously estimated, as high as 380 to 450,000 preventable adverse drug events annually. And that's just in the hospital setting. If you look in long-term care facilities, the Gurwitz and colleagues in 2005, their study suggested that maybe we have as many as 800,000 adverse drug events in these long-term care facilities. And in the outpatient setting, among Medicare patients alone, Gurwitz estimated 530,000 adverse drug events. So these happen all the time. The cumulative impact of these ADEs is something on the order of $3.6 billion per year in excess expenses due to hospital adverse drug events. That's for follow-up lab testing and management of the adverse drug event and so on. The Institute of Medicine defines a lot of different types of errors, not just adverse drug events. They identify errors in diagnosis where there may be an error or a failure to employ a specific indicated test. Perhaps you're using an outmoded test or therapy, or you're not acting on the result of a monitoring test or some other assessment. There can also be errors in treatment, of course, that maybe you've performed the wrong operation, the wrong site surgery, the wrong procedure, or the wrong test. Maybe there's an error in administering the treatment or in the dose or method of using a drug. And I'll give a very dramatic example of that medication dosing error and how it actually reached a patient in the human-computer interaction lecture. Perhaps there's an avoidable delay in the treatment or in responding to an abnormal test. This is a unique and I think fascinating blind spot in EHR design, that the ability to follow up on abnormal tests and to raise the awareness of those abnormal tests is still a little bit of a vulnerability. And maybe you've received inappropriate or care that's not inappropriate treatments or care that's not indicated. The IOM also highlights errors in prevention, so failure to provide a prophylactic treatment or inadequate monitoring or follow-up of a follow-up treatment. And then there's this category of other, where you have a failure of communication between parties in the health system, an equipment failure, or some other system failure. And unfortunately, all of these contribute to hazards. They put patients at risk unnecessarily. So beyond safety, there's other reasons why quality of the healthcare that we deliver in the United States may not be entirely that good. And one of the big indicators we look at is the value of our healthcare system. Value has a very precise definition in the quality improvement world. A unit of value is equal to the quality, the unit of quality divided by the unit of cost. So in this definition, you can have low value care either because it's low quality or because it's very high cost, or both. And conversely, if you want to improve the care, you can do so by reducing the cost of the same care or by improving the quality, or both. And unfortunately, what happens is when you look at the U.S. healthcare system and you compare us to other developed countries, we lag behind in many markers of sort of consistent healthcare. So the first of these indicators is actually cost itself. And by definition, if you're providing the same level of care to two different patients and one patient is paying twice as more, that patient's seeing less value. So twice as much, then they're seeing less value. So if you look at the U.S. healthcare system, we spend 2.5 times more than the average of these countries in the OECD, the Organization for Economic Cooperation and Development. These are sort of benchmark developed countries, and 2.5 times is a staggeringly high number. You can see the OECD line is in the middle of the graph, that red bar, and the United States is way, 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 way to the left, the furthest to the left, with a giant gap between us and the second most expensive healthcare system, which is Norway. We also have the largest fraction of private health expenditure, almost 50%, it looks like in this graph. Perhaps you could argue that, well, that's because we're a wealthy nation, so we can afford to spend more. And even if you control for your gross domestic product, we're still spending nearly twice the OECD average on healthcare. So we spend, as of 2010, or I think this may have been 2012, we spend close to 18% of our gross domestic product on healthcare, which again is a tremendously high number. That's basically almost 1/5 of the gross domestic product of the United States is in the healthcare sector. The next most expensive country here is Netherlands, and they only spend 12% of their GDP on healthcare. One might try to argue that one of the ways to justify this excess expenditure in the United States is because our health outcomes are so much better. But that argument actually also wears thin. If you look specifically at life expectancy as just a general marker of overall health status, you'll see two things very interesting on this graph from the OECD. One is that there's a general linear relationship between health expense and average life expectancy. So it is true that the more you spend on healthcare, in general, the longer your population lives. So you can see where the UK is. There's some outliers like Japan where they spend reasonably less amount on their healthcare expenditure, but they have a unusually high life expectancy in the mid-80s. And then way off to the right, you've got the United States. So we spend way more than the United Kingdom, but we have worse life expectancy than they do. So again, we're an outlier in this regard as well. This is yet another way to look at the economics of this. Maybe you could argue, or you would try to argue, that because we're a wealthier nation, we are willing to spend more on healthcare. But there are other nations that are relatively wealthy that don't spend quite as much on healthcare either. And so there is this linear trend again with countries like Norway as being relatively expensive and spending a relatively larger proportion of their GDP per capita on healthcare. But if you look at the United States, we're an outlier. We spend a lot more per capita on healthcare than our GDP per capita would suggest. And on the flip side, very, very wealthy countries like Luxembourg have a very high GDP per capita, spend much less on healthcare per capita than the United States. Our general pricing structure for hospital services are also more expensive. So hospital services in the United States are over 60% higher than the average of these 12 other OECD countries. And you can see we're here on the far right. There are some pockets where we excel. Typically in acute care, the United States healthcare system does pretty well. So if you look at like 5-year cancer survival rates for breast cancer, we actually do great. We do better than the OECD average. And ditto for colorectal cancer at 5-year survival, where we're just slightly worse than Japan, but better than the OECD average. Conversely, we lack in some of the measures for primary care and ambulatory preventive care. So, for example, if you look at asthma hospital admissions as a proxy measure for how good asthma control is in the outpatient setting, you can see that we're all the way at the bottom of this. And our rates of COPD hospital admissions are also higher than the OECD average. Another way that the healthcare system in the United States delivers low quality care is that it's frankly inequitable, that there are health disparities that cannot be described in any other way other than population-specific differences in the access and the quality of care received. And these disparities between 2003 and 2006 alone probably cost the U.S. healthcare system around $229 billion. Some examples of these disparities are that infants born to African American women are 1.5 to 3 times more likely to die than other infants, that African American men are more than twice as likely to die of prostate cancer, that Hispanic women are more than twice as likely to be diagnosed with cervical cancer. And this is completely wrong. So all of this sort of begs the definition of what is quality. We've talked about safety, and we've talked about the cost of care, and we've talked about the equitability. Well, there's one definition that I've listed here from the IOM that basically says that quality is the degree to which health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. And in fact, the Institute of Medicine has broken that out into 6 quality domains, and I love this framework. I think it's a very useful way to think about healthcare quality because it suggests that there's many ways that we can improve the quality of the healthcare system beyond just improving the safety of the system or reducing the cost. So safety, of course, is the number one on this list. It was first described in this IOM report in 1999, or first brought to light as a quality domain in 1999. And the estimates, again, are roughly 1 million people injured and 44,000 to 98,000 who die annually as a result. High quality care, in addition to being safe, must also be effective and reliable. So what does that mean? Well, that means that the care you're providing is evidence-based, that there's a scientific basis for providing it, that you can be certain that the benefits outweigh the risks and you're not taking unnecessary risks, and that the care is consistent, that patients receive the same standard of care regardless of where they receive it, when they receive it, and from whom. High quality care should be patient-centered. It should meet the individual's needs. It should incorporate and adhere to their values and preferences. It should be tailored to their language and level of education. It should focus on all kinds of care, including their emotional support, pain relief, attention to suffering, family support, and so on. High quality care is efficient. It avoids wastefulness and redundancy, and it should match the access to the demand. So high demand areas should have better access, and vice versa. It needs to be timely. Ideally, we would want to avoid long waits, scheduling delays, and barriers to care. And finally, it should be equitable at both the population and the individual level. We need to work harder to reduce the disparities that are attributable to age, gender, race, education, disability, sexual orientation, and more. There's been a lot of national activity around trying to improve the quality of the U.S. healthcare system. Most of it's been led by the CMS, is probably the largest payer in the country. The Center for Medicare and Medicaid Services, because they control such a large part of the reimbursement structure, actually do have a lot of weight in this. And many times the direction that CMS goes is the direction that all payers will eventually follow. And so CMS has published these clinical quality measures, or CQMs, that actually, as it's relevant to the electronic health record, define the appropriate use of EHR technology to support clinical practice. And you have to submit this clinical quality data in order to receive meaningful use incentive dollars. So back when we were submitting stage 1 and stage 2 reimbursement data, we had to prove that we met these clinical quality measures. A lot of these CQMs are actually derived from NQF, or National Quality Forum measures. And recall that CMS administers the EHR incentive program, which is changing over these days, but the funds initially that were dispersed totaled about $21 billion to participating providers, eligible providers and healthcare systems. The National Quality Foundation, or NQF, is an organization that's responsible for collecting and standardizing quality measures, and they publish them in a tool called QPS, or the Quality Positioning System. Every NQF endorsed measure has a number, so you can reference it, and it identifies who the steward is for that quality measure, and also the last time it was updated and revised. It also provides a lot of detail about how to actually collect and calculate that measure. This, of course, is extremely useful, in fact necessary, if you're going to do any benchmarking. If your hospital and my hospital are both trying to compare our rates of hospital readmission, we need to make sure that we're calculating those rates the same way. So, for example, here's the NQF example for the NQF measure for appropriate testing for children with pharyngitis is NQF 0002. The measure steward is the NCQA. The description is that this is the percentage of children from 2 to 18 who received a diagnosis of pharyngitis, who had strep testing, and received antibiotics. It goes on to describe the numerator, that this is the population for whom a Group A strep test was performed in the 7-day period from 3 days before to 3 days after the index episode. A denominator, which is that children ages 2 to 18 as of 6 months prior to the measurement period who had an outpatient or ED visit with only a diagnosis of pharyngitis. It also includes risk adjustments and exclusions and things like that. But that's a pretty detailed description and sufficient enough to allow hospitals to calculate this rate. Doesn't mean it's easy to calculate it. It just means that there's enough data here that you could do it. Other stakeholders in this include the Joint Commission, which is a nonprofit organization that accredits U.S. healthcare organizations. The Joint Commission is responsible for establishing what they call NPSG, or their National Patient Safety Goals. And in recent years, some of these goals have been things like reduction of multi-drug resistant organisms, catheter-related bloodstream infections, and surgical site infections. Another agency that's involved in this is the Leapfrog Group. And this is another voluntary program, and they were formed out of industry. They described 4 major leaps that they envisioned would improve safety and quality of the U.S. healthcare system. Initially, these leaps were the introduction of CPOE itself, and they also have gone on to recommend a list of recommended CPOE functions and safeguards. Evidence-based hospital referral, that is that patients are being referred for complex care go to high-volume centers of excellence. One of the leaps they recommended was for ICU physician staffing, that all ICU should be staffed with intensivists. And finally, they have this Leapfrog Safe Practice Score, which itself was a list of NQF-endorsed safe practices. So you can see how these different groups sort of borrow from one another. The NCQA, National Committee for Quality Assurance, which is the agency that created that pharyngitis metric on the 2 screens ago, is responsible for publishing and maintaining health effectiveness data and information sets, or HEDIS performance measures. The intent of this is to allow consumers to benchmark various health plans. And it's also involved, we require these for the process of physician and hospital accreditation. In fact, if you're a Medicare Advantage subcontractor for CMS, like an HMO, you're required to collect these HEDIS measures. Another agency that's, of course, very active in this space is the Office of the National Coordinator for Healthcare IT, or the ONC, established in 2004 as part of the HITECH Act mandated in 2009. This is also what we refer to as Title 13 of the ARRA, the American Reimbursement Recovery Act, otherwise known as the stimulus package. And this agency oversees the national activities to promote health IT. They were the group that established those initial certification criteria for electronic health records. Recall when every organization had to adopt a certified EHR system to be eligible for MU funds. And they also established these healthcare interoperability exchange standards. Healthcare information exchange. Most of the recent developments and probably the future direction for these quality measures involves this set of complicated acronyms, MACRA, MIPS, and APMs. So MACRA is the Medicare Access and Chip Reauthorization Act of 2015. It's a new payment program. People have referred to it as sort of the new MU that incentivizes value and patient-centered care. Their proposal is that starting in 2019, physicians will receive payments through MIPS or APMs. And MIPS are merit-based incentive payment systems. APMs are alternative payment models. The goal here is to ensure that reimbursements are tied to demonstration of high-quality care, not just quantity of care. And so we get more and more towards this notion of paying for value and not just paying for procedures that we do or tests that we run. So MACRA rates physicians based on these NCQA quality measures, including those HEDIS performance scores. And they have these additional components of they work to designate patient-centered medical homes, PCMHs, and patient-centered specialty practices, or PCSPs. They will also look at your meaningful use accreditation. So here's how all this fits together. You've got the patient quality reporting system, the PQRS. You have the meaningful use attestations that demonstrate you meet those criteria. You have these value-based patient modifiers, or VBPMs. And together, they're being consolidated into MIPS, the merit-based incentive payment system. Here's an example of how the MIPS composite scores that will be tied to reimbursements are proposed to be calculated over the calendar years 2019, 2020, and 21 beyond. And what changes here is the proportion of the reimbursement that's calculated due to resource utilization. So you can see, for example, that the degree to which the provider participates in clinical practice improvement activities is fixed at around 15% across the years. That the amount that relies on advancing care information, which is basically like the EHR use and meaningful use portion of this, is fixed at 25%. But then the balance shifts from these quality measures to resource utilization over the 3 years, where quality goes from 60 to 50 to 30% of the reimbursement formula, and conversely, resource utilization goes from 0 to 10 to 30%. So now we've looked at kind of the motivations for and the agencies involved in promoting quality activities in the United States. The next part of this talk is to talk about how we intend to actually improve. And we're going to go through and talk about a lot of these error-proofing concepts, thinking about safety as sort of the hallmark for this. The first concepts are things like high reliability systems. So how do you ensure that when you take a complex process that's very repetitive, that has lots of fallibilities and vulnerabilities, and make it highly reliable? This is what often draws the comparison between healthcare and, say, like the airline industry or other high-performance sectors where the tolerance for errors is extraordinarily low. Checklists are a very common and effective error-proofing strategy. And we'll talk about this metaphor that compares vulnerabilities in a process to layers of Swiss cheese. So James Reason's Swiss cheese model that all of you should be familiar with. And in this model, the vulnerabilities, the likely failure mechanisms of a process can be thought of like holes in a slice of Swiss cheese. And the steps in the process can be thought of as sequential layers of cheese. And what happens is, in order for a hazard or a risk to lead to patient harm, all of those holes in the cheese have to line up, that all of the safeguards at all the various steps have to fail, and this error has to sort of weasel its way through the system, which is why this is sort of a nice visual metaphor. So here's a typical surgical safety checklist. This one happens to be the one that's described by the World Health Organization and Atul Gawande in the Checklist Manifesto. And it's a paper form. You could think about making this computerized, but the original WHO version was paper. There's 3 phases: before you induce anesthesia, before you make the skin incision, and before the patient leaves the operating room. These are the things you're supposed to verify at the correct point in time. And the question is, does this work or not? Does this improve surgical safety? Well, this was published in 2010 in this manuscript, The Effect of a 19-Item Surgical Safety Checklist During Urgent Operations in a Global Patient Population. They looked at 1,750 consecutively enrolled patients who are over 16 years of age at 8 hospitals across the world. And what they saw was that with a very, very significant p-value, they saw a reduction in the complication rate from 18% to about 12%. They saw a reduction in the mortality rate, greater than 2-fold decrease in the mortality rate from 3.7% to 1.4%. And they saw a better improvement to the 6 measured safety steps from 19% to 51%. And all this was just from a paper checklist. Here's Reason's Swiss cheese model, showing how if the holes line up just right, your hazard can make its way all the way through and lead to a loss. In our healthcare example, imagine you have a hazardous medication. You know that it's a risky medication to prepare and to order, to prepare and deliver, administer, and something happens in the order entry step. Maybe the formulary itself is outdated. Maybe your order entry system doesn't make this any easier, and it makes it actually quite easy to commit a dosing error because it doesn't give you appropriate guidance, or it commits a rounding error in a silent way. Maybe when this inaccurate dose gets to the pharmacy, the pharmacist, because you don't have standard concentrations in that area, is forced to manually compound this oddball dose and messes up in that step. And then finally, imagine that at the bedside, when the nurse is administering the medication, he or she doesn't do the safety check, doesn't verify the dose, and administers to the patient, and suddenly all of these holes have lined up, and the patient has gotten an inaccurate dose. The logical sort of solution for this is either to add more pieces of cheese, other safeguards in the process, or to plug the holes, to reduce the vulnerabilities at each step. And I think that's what makes this such an appealing endeavor in that second step, the order entry step, where we really do have the ability to guide providers to better dosing, more accurate dosing. I think that's also the reason why, going back to our CDS lecture, why it's been so clear in the informatics literature that CPOE can actually reduce prescribing errors, because that's, in the paper world, was such a vulnerability that we've patched up a lot of those holes in the Swiss cheese. There's your adverse drug event. Another useful way to think about the likelihood of a specific vulnerability causing harm and the degree to which an organization should prioritize fixing it is this technique called failure mode and effects analysis, or FMEA, which was devised by the U.S. military back in the 1940s, and it's been used widely in aerospace and the automotive industry, and later adopted for healthcare use. So in this model, all the ways that a specific clinical process can fail are prioritized according to risk, and you measure this risk. You calculate the estimated risk of something based on the severity of the failure. So, how bad is the outcome? If this step fails, how likely is it to harm the patient? How severely will it harm the patient? The frequency of occurrence, which is how often does this process happen and how often does it fail? So that's the one that's the likelihood of occurrence. And the detectability, in other words, If this error was made before it reaches the patient, could you intercept it? Is it so apparent that a failure in this step would be 100% preventable? Or is it a silent error that would not be noticed until the patient had harm reach them? So how do you do a formal FMEA analysis? Well, the first thing you do is you have to map out your entire clinical process. And this is a fairly cumbersome step, especially if you look at like a specific complex clinical workflow. But then what you're supposed to do is, once you've outlined that clinical process in exhaustive detail, every step along the way, you go through and you look at each step as a possible failure point, and you say, does this step ever fail? Or could it fail? And if it does, or if it could, then you perform this calculation on it, where you, on a scale of 1 to 5, you describe the severity of harm. And there are some standard scales for doing FMEA in healthcare. This one's a little bit made up, but imagine that on our scale, 1 means no harm would ever reach the patient as a result of this step breaking down, and 5 means that if this failure did reach the patient, that it would be fatal, and then everything in between. So that gives you a number from 1 to 5 in the domain of severity, or S. And in the domain of the likelihood of occurrence, imagine that a very rare disease gets a 1, and an extraordinarily common disease gets a 5. And that in the detectability domain, the question here is whether your existing controls would identify the failure or not. So, for example, if you always verify the site of surgery by using a sticker, or forcing somebody to go look through the chart to see what site this surgery is supposed to be on, then maybe that's more easily detectable than some other type of vulnerability. So again, that's a 1 to 5 score. And all of these ordinal scores are created in a way that 1 is better and 5 is worse. So then you take those 3 factors, the severity, occurrence, and detectability, and you multiply them together, and you get another ordinal score, which is the risk priority number. And the reason it's ordinal is because it's not an interval, which means that I can't say that if something has an RPN of 10, that it's twice as unsafe as something with an RPN of 5, because there's no such thing as like twice as fatal or twice as detectable or something like that. So this can tell me the relative priority of these different vulnerabilities, but this is simply an ordinal scale. It's not an interval or ratio scale. And in this example, let's say we had a vulnerability that if it actually broke down at that step in the workflow, the result to the patient would be that it's fatal, but thankfully it's very rare and it's easily detectable. So that would get a 5 times 1 times 1. So Avitas Donabedian in 1966 described in this quality framework 3 types of quality measures, which we've talked about 2 of these, the process and outcome measures, in the clinical decision support lecture. And I want to introduce a third one, the structural measure. So if we're measuring quality, we can do so by measuring the structure of care, which refers to the attributes of the setting in which care occurs. For example, the number of clinical guidelines you've implemented in your institution, or the number of specialists that you have to care for a population of a specific patient group. One step up this sort of quality ladder, you can look at the process of care, which is measuring how care is actually given and received. In this case, I'm looking at whether or not my providers are actually doing the right thing. So the proportion of diabetic patients who are screened correctly for proteinuria, the proportion of children with otitis media who are treated appropriately with narrow-spectrum penicillins, and so on. These are all measurements of how we actually deliver the care. And then finally, there's the outcome measures, which are the effects on the care on patient status. These can be intermediate results like hemoglobin A1C for diabetic patients, or the lipid profiles for patients with hyperlipidemia, or they can be end measures like quality of life measures for patients with degenerative joint disease, or the functional status for a stroke patient following their therapy, or patient satisfaction scores, as an example. And there's sort of an implied rigor here that outcome measures are the hardest to measure, but also the most meaningful, whereas process are one tier down from that and structures one tier down from that. I also wanted to make the point that you could take a single clinical quality goal and phrase the quality metric in such a way that it could either be a structure measure, a process measure, or an outcome measure. So, for example, let's say we have this goal that all emergency department rooms should be stocked with equipment for bag mask ventilation. And there's lots of ways that you could possibly think about measuring the quality and to see if you're achieving that goal or not. The first is looking at it as a structural measure. Does your hospital have a policy or standard that specifies what equipment should be in every room in the ED? Because if you don't, that's a good place to start. The second one might be a process measure, that in weekly audits of your emergency department rooms, what percent of the time do you find a room where it's improperly stocked, that there is no airway equipment in the room? And so in that sense, the process measure of interest is that you want to see a lower defect rate in these periodic rounds you do on the rooms. And then finally, there's the outcome measure, which is that when it really counts, when you actually have a trauma or resuscitation event and you need a way to ventilate the patient using a bag mask setup, how many times has it taken place, has it occurred that the equipment is missing when you really need it? In other words, how many safety events have reached the patient where they couldn't be ventilated because of missing equipment? Now, the answer to number 3 might be almost never, and that would be the most desirable state. And so you may find that the process measure is not only easier to measure, it's probably more appropriate, because you can't possibly power your quality evaluation in such a way that you could detect extraordinarily rare events like outcome measures. Another way to think of that is that you can think of your process measure as your leading indicator and your outcome measure as your lagging indicator. So a leading indicator in the quality improvement lingo is an indicator that anticipates future events and that in which changes are detectable before the event occurs. So in the example of the bag mask ventilation in the emergency department rooms, if it's true that having a process to stock the bag valve mask setups in the rooms would prevent the adverse outcome, you would see that every adverse outcome is preceded by an event where somebody failed to stock the room with the correct ventilation setup. Other examples of leading indicators are things like physical activity, that you can measure sedentary lifestyle as a risk factor for some other downstream event, the patient's weight, their immunization status as a leading indicator of whether or not a population might have a pertussis outbreak or a measles or mumps outbreak. Antibiotics given prior to surgery is a leading indicator that in some sense anticipates whether or not the patient would be at high risk for a surgical site infection. Timely corticosteroid treatments for acute asthma, and so on. Whereas a lagging indicator are the ones that have followed the event and tend to be the things that actually reach the patients, like infections in a patient, which are a lagging indicator, caused by a drop in hand washing rates, which would be the leading indicator, or ventilator-acquired pneumonias, lagging, caused by failure to adhere to standard bundles of care, leading. Other types of complication rates, asthma hospitalizations and such. So I think it's useful to keep these pairs in mind, that you should think of leading indicators as process measures like the rates of pediatric immunization, where lagging indicators can be thought of as outcome measures like the rates of pertussis and measles in the community. So what makes a good healthcare indicator? Well, first of all, a good indicator has to be agreed upon. If your institution and my institution are both trying to improve a specific quality domain or achieve a specific quality goal, we both have to agree ideally on how we're going to measure that indicator of quality. it should be optimally sensitive and specific. So back to the decision-making test, decision-making lecture. To what degree does this quality indicator actually discriminate good care from bad care? In other words, does a higher number always mean better care, and does a lower number always mean worse care? I'll give you an example of something that may not be a great indicator, which is for a complex process like medication reconciliation on the inpatient side, the attribution is very hard to measure. So just because the attending physician is not marking the medication list as reviewed, that doesn't mean that medication review was not done. So if you create a process whereby you're looking at a specific individual's contributions to something like the medication reconciliation process, what you might find is that it's neither sensitive nor specific for good and bad medrec. Good indicators must be valid. In other words, they must be able to discriminate. This one's a little bit related to the previous one, between good and bad quality. They must be reliable, which means if I measure something repeatedly, my measurements should be stable and reproducible and consistent. They need to relate to identifiable user events. In other words, there needs to be a clear link between the cause and the effect. If you're not sure which user is causing a certain field in your electronic health record or clinical data warehouse to populate, which user action, it's really hard to use that as an indicator for anything because you can't be sure of the cause and the effect. It needs to be able to permit useful comparison, and finally, it should be evidence-based. It ideally is not just a made-up quality indicator. There's a long and rich history in quality improvement that starts with the manufacturing world, actually. One of the earliest proponents of quality improvement for manufacturing and process control was at the turn of the century, Frederick Taylor, who started what we now call the scientific management movement. And Frederick Taylor believed that management was a science, that you could actually compel people to perform better by monitoring their performance over time. And while that's true, by modern standards, it seems that he thought pretty poorly of workers. He put a lot of weight on what the manager's role was and thought workers were pretty much grunts. And so these are some direct quotes from some of Frederick Taylor's writings. In the majority of cases, this man deliberately plans to do as little as he safely can, speaking about the inherent laziness of the American worker. And when he tells you to pick up a pig and walk, you pick it up and walk. And when he tells you to sit down and rest, you sit down. You do that right through the day. And what's more, no back talk. So he's talking about the responsibility of the worker to listen to their manager regardless of what that the manager is asking them to do, to be obedient workers. So, I'm not convinced this culture would fly in the healthcare setting, and I would not encourage you to try it either. But there are some concepts that Taylor espoused in the scientific management movement that led to improvements in the future. One of the major leaps was the creation and the standardization of what's called statistical process control, or SPC charts, by Walter Shewhart from the Western Electric Company in the 1930s. Shewhart realized that if you had repeated measurements of a process over time, that they tended to be stable with some definable variability, and that furthermore, you could see drifts in that process and you could detect changes in that process simply by watching it over time and measuring it to previous values. So this is a very, very important concept, and we'll talk about it in more detail. In the 1950s, as Japan was recovering from World War II, Taiichi Ohno developed something called the Toyota production system for the Toyota automotive manufacturers. It's now become known as Toyota Lean, the Lean methodology. And this is the system whose sole purpose is to remove all activity that has no value or that contributes to waste. And the word for waste in Japanese and in the Toyota Lean framework is muda, M-U-D-A. There's actually a number of different types of waste, but that's one very specific type. In the 1970s, Deming, who was hired as a consultant to improve production methods in post-World War II Japan, also proposed a quality improvement framework called the Plan, Do, Study, Act, or PDSA cycle when he espoused his theory of improvement. Now, if you look at this slide and the slide immediately before it, there are 4 names, 4 different time periods, and 4 different sort of statistical concepts that Deming introduced: the Plan, Do, Study, Act, that Taiichi Ono defined the Toyota production system, that Walter Shewhart created control charts, and that Taylor was the founder of scientific management principles. Those are very testable facts. In fact, an easy testable bit of knowledge might be, to match the name of the QI figure with the theory that they espoused or the technique that they developed. Now let's talk at Shewhart's control charts. The first thing, actually the hardest part initially for me to get my mind around, was that these are not hypothesis tests. And for many of us who come from sort of standard medical training and who didn't get quality improvement training back in medical school, all we knew about was p-values and such, and the null hypothesis. So if you can, for a little bit, sort of abandon that notion, because this is not meant to prove or disprove a null hypothesis. Instead, what this is meant to do is to identify when variability in a process is due to common cause, meaning it's innate to the process and nothing to worry about, or special cause, which means that there is an external influence that's likely to have resulted in this. And these definitions are based in statistics. And again, it's based on this notion that when you monitor a process over time, an indicator will fluctuate around an average value, which you can calculate the upper and lower control limits, this sort of statistical boundaries of that fluctuation. So here's what it might look like. You remember the standard distribution, the normal distribution, where about 68% of all observations will fall within 1 sigma of the mean, the measure of central tendency, and 95% of all observations will fall within 2 sigma of the mean, and a full 99.73% of all observations will fall within 3 sigma of the mean. So if you have an observation that falls outside of 3 sigma, you can be very certain, or fairly certain, less than 1% unsure, that this is not due to random chance. And so one way that I visualize what these repeated measurements look like over time is imagine your normal distribution, and you've turned it sideways, and you basically map where that 2 sigma and 3 sigma line go. So in this example, you can see that the process, for the most part, is between the center line and the 2 sigma line, with one point that jumps up between 2 and 3 and then comes back down again. Now the upper control limit and lower control limit, which are the +3 and -3 sigma limits, again are expected to contain 99.73% of all observations. The upper warning limit and lower warning limit, which are the + and -2 sigma limits, are expected to contain 95% of all observations. There are very specific ways that you calculate the boundaries for those limits, and it depends on the type of data and the type of control chart you're doing, because you may have unequal samples in different time periods, or you may have the same number of samples. They may be limited to a certain number, or they may be unlimited, and all that changes how you measure that the control limits. And while you're probably not going to be expected to know what the different control chart types are, you should be aware of the fact that there are many different types of control charts, more than I've listed here even. And basically you have to go through a flow chart to determine which type of control chart is appropriate for your type of statistical analysis. So for example, the first branch in this is based on what type of data you're trying to measure. Is it a count or a classification? Are you trying to say something is a defect or not? Are you counting the number of errors in a process? If so, then you have to go to the top branch. Otherwise, if it's a continuous variable like time, money, throughput, number of patients seen in a process, productivity, or something like that, or something that can be measured on a scale like height or weight, that goes to the bottom branch. Once you're in that count and classification, you're looking at are you counting the number of non-conformities, like the number of defects in the process or the number of errors? Or are you classifying the non-conformities into pass, fail, and yes, no? The difference here is that in the top, you can have more than one defect per unit in your denominator, and therefore the numerator can exceed the denominator. And in the bottom, because it's a dichotomous outcome, it's either yes, no, pass, fail, the numerator is always a fraction of the denominator. It cannot exceed the denominator. So if it's in the top, then you know you're going to be either in what's called a C chart or a U chart. If it's in the bottom, then it's a P chart or a proportion chart. And the letters refer to basically the type of chart. So P in this terminology refers to proportion. U refers to unequal area of opportunity. C refers to count, I believe. In the bottom half of this flow diagram, or sorry, this branching chart, the two different options are an I chart, sometimes known as an X chart, or an X bar and S chart. And again, I'm not going to get into the details of what those represent, but you can read those. So let's look at some examples of where I'm trying to count something. So if I want to measure the number of workplace injuries per month over time. So first of all, I'm counting the number of events. So I know that this is going to be one of my count measures. There is an unknown denominator, and the numerator can exceed the denominator. In other words, it's theoretically possible that you have more injuries than you have employees, and there's no upper bound on the number of injuries. And there's an equal area of opportunity, meaning that typically the workplace does not change in size from time period to time period. There's a relatively stable number of employees. And because this is count data with a numerator that can exceed the denominator and an equal opportunity area of opportunity, this is a C chart, a count chart. If we look instead at the number of line infections per 1,000 patient days, now we still have count data. We still have a numerator that can exceed the denominator. You can have more. The same line can be infected more than once, and you can have more than one infection per day. And there's an unequal area of opportunity because the number of patient days can change per observation period. And so in this example, you would use a U chart for unequal. The third example here is let's look at the proportion of patients who had medication reconciliation performed correctly per encounter. This is a count data. We know the number of patients, and this is a dichotomous outcome. You're either saying that MedRec was performed or it was not once per encounter. And in that sense, the numerator cannot exceed the denominator. I'm looking at the proportion. The tip-off here is that they told us they're looking at the proportion of patients, and therefore this is a P chart, or this would require a P chart. Here's some more continuous variable examples. Let's say I wanted to explore the variation in patient days per month. This is not a count or a classification of nonconformities. There's a scale to this, which is days or time. And the measurement is individual patient days, not an average. And so in this example, you would choose an I chart, and here I means individuals. If we're looking at the time it takes to get the patient from the emergency department to the OR for a number of sequential cases of isolated femur fracture. So you're looking one by one by one. Every time a patient comes in with a femur fracture, you measure how long it takes for them to get to the ED to the OR. Here the scale is time. These are individual measurements per case, and they're sequential measurements per case. Therefore, you would choose an I chart, that same chart, the individual chart. Some other continuous variable examples. Average turnaround time for stat CBC tests per month. The key here is the average. So time is a continuous scale, so we know it's not one of the count-based items. The measurement is an average, not an individual observation, like in the previous examples of the femur fracture. And therefore, we're choosing an X bar chart. The bar there refers to the fact that you're looking at an average. The next one is similar, an average cost per appendicitis case. In this case, you're looking at the scale is cost. It's a time value, not a count. Sorry, a monetary value, not a count. you're looking again at the average, and therefore this is also an X bar chart. So you've constructed your control chart, you've constructed your upper and lower control limits, and now you're trying to figure out whether the statistical variation you see is expected or not. And now we have to introduce these two new concepts, common cause fluctuation or special cause. And common cause, again, is any variability you see in the process that's within the upper and lower control limits, again, which we expect to cover almost 100%, but not quite 100% of all the random fluctuations, and which has no unnatural patterns which suggest some sort of statistical variability or drift. And then special cause is any observation that falls outside the upper and lower control limits, which means it's in that fractional 0.25% that's outside the 3 sigma limits, or that meets any criteria for special cause pattern. And you might be asking yourself, what is a special cause pattern? Well, here's a lot of examples of special cause patterns. Basically, what Shewhart identified was that in addition to any single point being outside the 3 the sigma levels, upper and lower control limits, there are other ways that something can be statistically improbable. Specifically, well, you could have the single point outside of the 3 sigma, but if you have 2 consecutive points, 2 out of 3 points between 2 and 3 sigma, that's statistically unlikely. It's very unlikely you would get something twice in that interval between 2 and 3 sigma, and so that suggests special cause. If you have 4 out of 5 consecutive points beyond 1 sigma and on the same side of the center line, that also suggests something that's statistically unlikely. It's like the likelihood of some abnormal event always happening 5 times in a row. The next one is 8 consecutive points on the same side of the center line. And think about, like, for example, flipping a coin and getting heads 8 times in a row. That's statistically unlikely and might suggest special cause. 6 in a row increasing or decreasing in the same direction suggests a drift in a process. And there's others too, but these are the sort of the most common ones. So let's look at this graph. So I'll give you a hint. What I did here was in Microsoft Excel, I created a random number function, and I took a process and varied it around a mean. And then at some point in the graph, I simply downshifted all those values by multiplying the values by 80% or something like that. And the question is, would a control chart detect that change, that all of a sudden there was a change in the measurement itself? And so we're going to test that hypothesis. I put in the center line, 89.6, with the upper and lower control limits and warning limits, 99, 96, 83, and 80, as shown there. And the question is, what are the various special cause indications in this graph that tell us that this process has been perturbed? So you may have picked out that there's 2 points that are beyond 3 sigma. So immediately we know that something around time period 14 was the first indication that there was special cause. You might have also picked out that there's 2 out of 3 points between 2 and 3 sigma, and that special cause pattern actually happens twice towards the end. We have 8 consecutive points on the same side of the center line. So that's an abnormal finding. You would not expect to see that pattern if this was common cause variability. So in that previous example, you can see that in fact those special cause rules did work. There's a few other types of special cause terminology that you should be aware of, a few other definitions. A shift is a run of 6 or more points on the same side of the center line. A trend is 5 consecutive points going in the same direction. A run is too few or too many events crossing this center line. A cycle is when you have periodicity in the data. So for example, let's say delays in a process always occur at night. Well, maybe it's because the staffing is different at night, and that suggests you have special cause. And then a pattern is when there are cycles in the data that are attributable to other factors besides time. Every time a specific pharmacist is on duty, you see a higher number of medication errors or something like that. And what's the value of using control charts? Well, for that, I actually turned to our Chief Quality Officer at Children's Hospital, Dr. Ron Caron, who shared this example with us. That imagine you had a process where you're counting the number of defects. This could be whatever, failure to adhere to a bundle. It could be the number of bloodstream infections or whatever the quality indicator is that you're following in your institution. And you might see that we have this general pattern here. And as a leader or a decision maker in your institution, you might be tempted to follow this over time and say, you know what, we can improve this. So you trend it over time. After 11 months, you calculate the mean to be about 21 defects per month, which you can calculate from these 11 observations. So I'm going to draw my mean there. And now, because I'm a good leader and I'm trying to improve my processes, I'm going to suggest, you know what, we can improve this by 10%. So I'm going to arbitrarily choose a target for improvement that is 10% less than what I'm seeing. So here's my new goal. And I've gotten my team all excited about it, only to find that once we continue to observe the process for the next 10 months or so, we see this. Every single point is above the goal. I might be tempted to panic and say, oh no, we've exceeded our goal and it looks like our metric is backsliding. We're not achieving the improvements that we had hoped to see. So Ron makes the point that what we did wrong was that we should have included the control limits from the very start. Rather than picking the mean and arbitrarily choosing a goal for this metric, we should have first started by looking at the lower control limits and upper control limits from those initial 11 points. And what you would find is that all of these observations, even the ones from months 12 to 20, were expected. In other words, they were within what we would describe as common cause variation. And so we may not like where that mean is. We may not agree that the mean is 21. We may not desire it to be there. But we can certainly say that this process is in control. So again, from drawing the control limits, you can see that the variation is due to common cause and cannot be attributed to special cause. It also might tell us that if we had done some quality improvement intervention in this interval between 10 and 11 months or whenever we set the new goal, that actually that initiative had no impact whatsoever. There's a whole host of other quality improvement tools, namely flowcharts, which are covered elsewhere in the curriculum, but think of this as a graphical way to represent a process step by step where you can model the inputs or you can describe the inputs, decisions, and outputs. There's the cause and effect, otherwise known as an Ishikawa, otherwise known as a fishbone diagram. The goal of these are to identify possible targets for improvement by looking at the head or the outcome of interest, the error that you're trying to safeguard against or the problem you're trying to fix, and then asking over and over again, why did this take place? How did this happen? And can you actually go back and identify the root cause of it? It's called a fishbone diagram because the head of the fish, which is where the outcome is, looks like it's connected to the ribs or the bones of the fish, which are the various rays or the domains on the diagram, which I'll show you in an example. A Pareto chart is also a very useful tool. It's a frequency sorted graph of the number of events that you're seeing with a cumulative percent line that allows you to determine sort of how much bang for your buck will you get. That if I fix the top 3 defects, how many of the total number of defects does that represent? And Pareto, as the mathematician who derived this technique or created this technique, is the origin of the what we commonly refer to as the 80-20 rule, that you might be able to address 80% of your safety events by fixing 20% of the causes. And again, it's a very useful way to commonly identify the most valuable targets for improvement. Finally, there's the key driver diagram, which is where you're trying to establish the causal pathway between the intervention and the aim. So you look at the desired outcome, improve safety, improve bundle compliance, whatever it is, and then you work backwards to figure out what are the drivers of that behavior, what would allow us to promote that behavior, and how can we change that behavior. So here's an example of an Ishikawa diagram. Imagine that we're interested in looking at the dosing errors of something called supercilin, and as we keep asking why, well, how did this supercilin dosing error occur? Well, it took place probably because we don't have a good way to direct the correct dose according to the indication for which the medication is used. And well, why is that? Well, that's because the ordering provider is missing the information they need at the point of care. So then you've gone back to sort of root cause number one. And then maybe the other contributing factor was that there had been a recent dose change, and that's another reason why the provider had ordered this inappropriately. And if you keep asking why over and over again, how did the recent dose change take place and how was the provider not aware? Maybe because the formulary was outdated. How did that happen? Well, because there was a communication gap between the group that's supposed to update the pharmacy and the group that is responsible for making sure it happens. And so that is a set of root causes attributable to the pharmacy, and so on and so forth. Here's an example of a Pareto chart. Let's say we're looking at the causes of errors related to the choice of antibiotics for a urinary tract infection. And we have a lot of infections. In fact, we had 12 events that were caused by wrong empiric antibiotic choice, 8 that were caused by the wrong dose, 3 that were caused by delays in antibiotic ordering, 1 that was caused by contaminated specimen, and another one due to misidentification of the morphology of the bug. And if I rank sort those according to their frequency, what I can see, especially once I overlay the cumulative percent line, is that 80% of the errors related to antibiotic dosing for UTI is attributable to exactly 2 causes, the first 2, wrong empiric antibiotic and wrong dose of antibiotic. So from this, I would take away that if I was trying to improve this process, I would need to focus on those first 2 measures. And I could, if I were able to fix just those 2 targets, I could theoretically improve this process by 80%. Here's an example of the 5 whys. This one's straight out of Wikipedia, but I like to think of this as sort of like the persistent toddler questioning their parent kind of thing. So I have a vehicle that doesn't start, and the first question is, well, why won't it start? Maybe because the battery's dead. That's great. You could actually stop right here, change the battery, and go on your merry way. But if you go through the exercise of asking that again, why is the battery dead? Well, it looks like your alternator's not working properly. Really, what happened to the alternator? Well, there's a belt in there that's broken. Again, you could stop here. You could either replace the alternator, you could replace the belt. But if you ask again, why is the alternator belt broken? Well, the belt should have been replaced. It was actually well beyond its useful service life and it wasn't replaced. Why was it not replaced? Because the vehicle was not maintained according to the recommended service schedule. So finally, we've gotten to our first root cause, which is that the vehicle was not maintained according to the service schedule. So the solution, the true solution to this problem, is not to replace the battery, not to replace the alternator, not to replace the belt. You probably have to do all those anyway. But if you want to prevent this from happening again in the future, you actually need to maintain this vehicle according to the service schedule. The author of this example also suggested a number 6, which was maybe you can't even find the alternator belts for this model because the car is too old, in which case the solution for that would be to purchase a different vehicle. So this is a way of thinking that I think is very useful because we're problem solvers in healthcare, but our tendency tends to be to fix the proximal issue and not always the root cause. And we have the latitude in the informatics world to really suss out, well, why did that dose error take place? What was confusing about that screen? Why is that confusing to the user? Why is that button placed where it is? And why do we represent the dose the way we do on this screen? So on and so forth. So I think this is a great exercise to go through when you're trying to safeguard a process. Here's an example of a key driver diagram. Again, these are a little bit different from the fishbone diagrams. The fishbone diagrams, you start with the defect or the problem you're trying to solve and you work backwards. In this one, you start with the goal, in this case losing weight, and then you work backwards from that to the likely drivers for that. So the first one's useful for identifying root causes, and this one's useful for identifying potential targets for improvement, potential interventions. So if you know that you're trying to lose weight, there's exactly 2 drivers for that. There's the number of calories in and the number of calories out. And the behaviors that influence calories in are perhaps for this patient drinking less soda or eating less snacks. And the ones that influence calories out is, for example, more exercise. So you can do this in healthcare also. You can identify the goal that you're trying to achieve and work backwards to the drivers of those goals. Okay, another useful framework we mentioned before was this Plan, Do, Check, Act, often more recently abbreviated as PDSA or Plan, Do, Study Act, along with Six Sigma and Toyota Lean. So each of these are quality improvement frameworks or methodologies. I encourage you to look at this supplemental reading, The Basics of QI in Healthcare, from the Mayo Clinic Proceedings in 2007. It's a nice overview of these techniques. Also, in the next couple of slides, see if you can compare and contrast these methodologies. Learn what they have in common and learn how they differ. So the first is the Plan, Do, Study Act or Plan, Do, Check Act. There's a great reference here on the Institute for Healthcare Improvement or IHI website on the page labeled How to Improve. The first step for all these quality improvement initiatives, regardless of whether it's PDSA or Toyota Lean or whatever, is to form a team. And that team has to establish a set of aims. What is it they're trying to accomplish, in what time period, and how do they intend to measure it? So then you have to define, well, what are the improvement measures? And ideally, these should be good indicators. So if you refer back to the slide where we talked about what makes a good indicator, well, they have to be sensitive and specific and reproducible and agreed upon and all that stuff. Okay, so now you have your aim and you have your measures. Now you have to identify the targets for improvement and the targets for intervention. And this is where those other techniques of failure modes and effects analysis, Pareto, Fishbone, and everything else become useful. That's all the pre-work. We haven't actually done anything yet. We haven't done any interventions yet. But now we can come up with a plan for improvement. We can actually implement the test of change and collect the data in a longitudinal fashion. We can study/check, which is when you put together your run chart and monitor the process using the statistical process control methods we've described. And then you can act on those results. So if you intervene and nothing changes, back to the drawing board. If you intervene and it works, then you iterate again and disseminate that finding to other areas. So this is a great example. This was a paper from Pediatrics in 2013 by some colleagues at Cincinnati Children's Hospital. It's a great prototype of a quality improvement practice, project done right. This hospital wanted to encourage appropriate first-line antibiotic prescribing for community-acquired pneumonia. First step, they formed a team that included hospitalists who were responsible for prescribing the antibiotic, participants from the emergency department, infectious disease specialists, pharmacists, and other types of providers. They got together as a group and they developed their aims. They decided that they wanted to increase the percent of patients who were admitted with community-acquired pneumonia on appropriate antibiotics from a baseline of roughly 0% to a target of 80%. And then they created a process map to understand their current workflows and to figure out where the opportunities were to fix this. What they noted was that it started as far back as the emergency department. They weren't going to pin this all on the inpatient docs. And that it was the ED's responsibility to diagnose bacterial pneumonia. They would decide whether to admit or not. They would actually initiate the initial antibiotics, the first-line therapy, and ideally they would be the ones responsible for picking that first one. The inpatient ward would then either agree to or disagree with the initial assessment of bacterial pneumonia, and if they agreed, they had to determine whether or not to change the first-line therapy or not. So there was a couple of steps where somebody could put the patient on the wrong antibiotic. And then they also had to continue this decision to the home setting where they were sending the patient home on the correct antibiotic. So a lot of steps here, a lot of potential places to intervene. So then they looked at the drivers of this behavior. And this is a key driver diagram. You'll see that their global aim was to reduce variation in the management of CAP in children by implementing evidence-based guidelines. And the specific aim of this study was to increase the use of appropriate therapy from 0% to 30%. And look at how that aim is worded. It's very precise. They define which children are going to be in the cohort that they're studying. They're defining which campus. This is the General Pediatric Service campus at Burnett. There's plenty of information here. They even say they even go as far as to define where they got their list of evidence-based first-line antibiotic therapies. They reference the ID Society for America Pediatric Pneumonia Guidelines. And then they asked, okay, well, what drives appropriate choice of antibiotics? Well, first thing is we got to increase provider buy-in. Next, we have to improve effective communication between the care providers, specifically at that handoff between the ED and inpatient units. Next, people have to know what the guidelines are. It's impossible to expect someone to prescribe the correct antibiotics if they don't know what they are. And then the last driver is that there needs to be a mechanism to accurately and correctly order this antibiotic. So from that, they define what their interventions were going to be. How could they increase provider buy-in? Well, they could do so by having a seminar on the guideline, promoting this at grand rounds, updating the medical staff about antibiotic recommendations, etc. The second one could be to improve communication, these charge nurse flag cards. I don't recall exactly what that intervention was, but you can go back and look through the paper. Another way that they were going to promote an accurate knowledge and better communication was to provide an index card, a little cheat sheet for the ED docs and the inpatient residents that would show them what the first-line antibiotic recommendations were. And then finally, they had this electronic medical record intervention, which was to modify the H&P template and the order set so it reflected and matched the ID Society for America guidelines with a link. And then they planned, so now they have their targets for intervention, and they planned it and they did it. They did these educational seminars, they created these 4x6 index cards, they included recommendations in their house staff guide, and so on and so forth. Perhaps my favorite part about this study is that they realized this was not just an electronic health record solution, but rather a process of education and process transformation that included electronic health record as part of the intervention, but not as the only solution. And here's their run chart. This one's a run chart, not a control chart, because there's no control limits on here. But even still, the results are completely obvious. Their original baseline was very low with these massive swings into the 50s and 60s percent. These are sequential, it looks like calendar weeks of service. There's unequal numbers of patients in each of the observation periods. And you can see that the first thing they did was they made the ID Society guidelines available back in August of 2011. Then they held a guidelines seminar at the campus in October, and that led to a very rapid uptake of these recommendations. And then they targeted it again with a resident report in January. They distributed the resident index cards in March. They made the EMR changes in April. And once they'd done all of that, look at those last 10 points where they basically have achieved 100% and stayed at 100% for the remainder of the observation period. And maybe it was the EMR changes that sort of crystallized this workflow and made it easy to adhere to. So this is the prototype of a quality improvement effort done really well. Six Sigma is related to PDSA. This was developed by Motorola in the 1980s. And the idea comes from, the name comes from the idea of having a process that's in control out to 6 standard deviations, or 6 sigma, which is basically an essentially perfect process. So if something was in control within 6 sigma, you would expect only 3.4 defects per million opportunities, or a process that's essentially 99.999% error-free. So that's the goal, is to have something that's essentially perfect. They define a series of steps that they abbreviate as DMAIC, which is similar to PDSA or PDCA. And DMAIC stands for Define, Measure, Analyze, Improve, and Control. I think the analogies between that and the PDSA cycle are pretty apparent. But again, first you come up with your team and the charter, the scope, the goals. Next, you come up with your data collection plan, the sources of data measurement, how you're going to identify defects, design your control charts, identify your solutions, implement them, and then see what happens. The most interesting of these to me is the Toyota Lean methodology. Taiichi Ohno in 1950s, again in Toyota Motor Company, was one of the corporation engineers, and he described there are many types of non-value added activities, including muda, which means uselessness or wastefulness, mura, which is irregularity or unevenness in a workflow. So, for example, wide fluctuations in your operating room or infusion center or census, and muri, which is unreasonable or burdensome work, otherwise known as internship. There's 7 different types of muda just by itself. There's overproduction and underproduction. There's inventory waste, which means, for example, having too much of a perishable good in stock because you're going through and having to throw out a lot of it. There's assembly mistakes or too many repairs and rejects. Like, yeah, you're getting doses out the pharmacy quickly, but 20% of them are the wrong dose. There's motion waste, that maybe your workplace ergonomics are constructed so poorly that people are wasting time just to get their tasks done as they move from here to there. There's processing waste. Maybe you have policies and procedures that are outdated and you're asking people to do all sorts of extraordinary steps that they don't need to. There's waiting. So people queuing in waiting rooms and things like that, that could be a symptom of something else, but in and of itself is also a type of waste. And there's transport waste, where instead of bringing the services to the patient, you're bringing the patient to all the different services and forcing them to go around the entire health system. All of these Ohno thought were very wasteful. I'll call out the motion waste. If you've ever seen a clinical area that's undergone sort of a lean methodology transformation, one of the techniques they do is to try to standardize a workplace such that anybody who picks up that workstation knows where to find everything they need. So an example of trying to reduce the variability or the ergonomics of something is the standardization of a code cart, right? We cannot have a situation where one code cart is stocked completely differently than another code cart, where in one of them the airway equipment's in the top shelf and another one the airway equipment's in the bottom shelf. And so you want to reduce motion waste and ergonomic distress by standardizing the layout of your code cards. And if you've seen one of these workstations where they've done a lean transformation, they may have tape all over the desktop that actually shows where everything goes, like a little rectangle of tape in the corner that shows you this is where the stapler goes, another rectangle in the front that says this is where the keyboard goes. And the idea is that, I'm saving these sort of molecules of ATP and attention by not forcing somebody who's coming to that workplace for the first time to have to look for where the stapler goes. They can anticipate where it's going to be almost immediately. Another technique in Toyota Lean is value stream mapping. And this is one where you actually describe graphically the inputs, throughputs, and outputs of a workflow or a process. And it's meant to highlight the opportunities for improvement. So where do you have excess inventory? Where do you have queuing when you don't need it? Where do you have too many defects? And one of the main things that happens with value stream mapping is that you ask the frontline staff to suggest ideas for improvement. And when one of their ideas is adopted and you decide to do a test of change, it's called a Kaizen event, or a change for the better. And these small sequential improvements in the aggregate actually become big improvements over time. Here's some other things that take place with Kaizen. So the goal of a Kaizen is to standardize your operational activities. There is a strong focus on measurement as well within Lean. You are trying to compare your measurements to your requirements. I think one of the great things about Lean is that it really does ask frontline staff to make contributions and identify opportunities for improve, since they're the ones who know sort of the pebbles in their shoes and what makes their work hard or easier to do. And when an improvement works, make them the new standard and then repeat. Here's some of the supporting conventions for Lean. The first is called a Kanban card, which is a visual indicator about the status of the stock of an inventory. Another one is an Andon, which is a visual indication that tells you the status of a certain process, whether something is taking place or not. And the third one is this concept of pokayoke, which means mistake avoiding. So within your healthcare organizations, perhaps on your hand sanitizer jars, you've seen these little 5-cent plastic red flip tabs. And you've probably asked yourself, well, what are those for? Well, the idea is that that's actually a type of lean Kanban. And if everyone's bought into this idea, excuse me, anytime you find an empty Purell canister or a hand sanitizer canister, you're supposed to flip up the red tab and then walk to the next one and try it again. And that has a number of benefits. One, if I see a sanitizer dispenser with the red tab up, I know it's empty and I'll know not to waste my time by going there. And two, if I'm the person who is responsible for stocking the Purell canisters, I know that I don't have to test every single one of them. I only need to focus on the ones that have a red tab flipped up. And three, if I'm the person who encounters an empty canister, I no longer have to deviate from my workflow and go tell someone that we're out of hand sanitizer in this area. All I have to do is flip up the red tab, and I can trust that there's a process in place to fix it. So this tiny little 5-cent plastic tab actually confers a lot of benefit to a lot of people in a number of different workflows. And it's that sort of way of thinking about improvement that I think makes Lean a very intriguing framework. The end on the example I gave here is that light outside your radiology suite that shows whether or not an X-ray is in progress. It's a great safety precaution. It prevents you from walking in without a lead apron and accidentally irradiating yourself. And another example might be a flashing light that indicates when a patient needs assistance, like the ones outside the patient rooms when they press the nurse call button. All those are visual indicators about the status of a process. The third one, pokayoke, there are lots of really great and subtle examples of this in real life. The ones that are relevant to medicine, for example, if you look at the medical gases, they're color-coded. Yellow is used for air and green is used for oxygen. And ideally, I've seen these at some health systems where the nozzles for these are mutually incompatible. In other words, if I'm trying to hook up an oxygen mask, it doesn't actually even fit on the wrong gas. Actually, the better example of that might be the inhaled anesthetics, where because there's huge differences between like the various inhaled anesthetics, these volatile gases, you don't want to risk filling the wrong container with the wrong anesthetic. And they actually have mutually incompatible spouts that they look like little puzzle pieces that you cannot fill the halothane jar with the sevoflurane bottle and vice versa. Another example that all of us probably have in our pockets is if you look in your cell phone and you pop out the SIM card, you'll notice that there's a little notch in the corner. And that notch basically makes it so you can't possibly insert your SIM card in the wrong orientation. It just won't fit. So pokayoke is this idea of sort of catching a mistake before it happens or engineering out the likelihood of that mistake happening in the first place. So, for those of you that are interested in trying your hand at some of this, take a look at this PDSA tutorial that's on the Ohio Perinatal Quality Collaborative website. There's a link here. And pick a hypothetical clinical quality improvement project of your own choosing within your own institution and kind of write out on paper what a PDSA cycle might look like for that. And that's the end of this lecture. So thank you for your time. All the suggested readings are at the end. There's a lot of useful references here. That Healthcare Quality book by Ransom, Joshi, and Nash. I think I referenced this one earlier. The Basics of Quality Improvement in Healthcare on the Mayo Clinic Proceedings is a great one. The IHI website is a fantastic resource. This is a free book that you can get off the PubMed website called Tools and Strategies for Quality Improvement and Patient Safety. IHI also has what's called an open school. You can register for all their quality improvement courses, and they even have a YouTube channel where they've got videos. And there's the link to that pediatrics paper from 2013 that I referenced during this talk, the quality improvement methods to increase appropriate antibiotic prescribing for childhood pneumonia. Thank you for your time.